So we're going to do head to toe assessment review, and on Blackboard you'll be able to find your rubric. It says Nursing 1200 Comprehensive Head to Toe Grading Rubric. There are 2 pages of criteria and items that you need to be able to get through. In order to be successful, you can only miss a total of 4, with the caveat that heart, lungs, and abdomen, you have to hit every single one of those items on there in order to be successful. We will also have you apply some sort of O2 device, whether it's a nasal cannula, a Venturi mask, or a non-rebreather mask. The instructor will tell you which one to do, or you might select a card that tells you which one to apply. You can do that as you go, or if you want to do it first, that's fine too. You'll have 10 minutes total to complete your head to toe assessment. You're also going to identify any abnormal sounds for the heart, the lungs, and the abdomen. Okay, so when we're starting out, of course, we want to have privacy for our patient. We do our hand hygiene. We'd want to raise our bed to a comfortable level. I do have the bed raised already and the rails down just so you can see what I'm doing. Always provide for privacy. We get our patient identifiers, name and date of birth. We confirm those. So this is Mary Jean Johnson, and her birthday is 5/14/62. And we see that she has an allergy band on as well. We would want to notice any kind of devices that they have applied. Maybe they have, like she has an IV in her arm over here. Maybe they have an NG tube in their nose. Maybe they have a Foley catheter. So we're looking at the entire person as well as any equipment that they might have on. To start, she gave me her name and date of birth. I told her that I'm Sam, I'm her nurse for this morning. We're going to do a head to toe assessment. We did vital signs already, and she's actually running a little on the low side with her pulse ox. So we will do oxygen first. Let's say her oxygen's at 90%, and my instructor told me to do 3 liters nasal cannula. And we want her to be above 93% per the order. So we select our device, which this is a nasal cannula. I'm going to hook it up. I'm going to dial it up to 3 liters per minute, which will be the ball will be perfectly centered at the 3. I am going to make sure that I feel oxygen coming out, and then I am going to put the prongs like this, and that's going to go into the nares. Now on the mannequins, these nasal cannulas don't want to stay very well, just so you know. But it wraps around each ear, and then you snug up at the chin with this. Okay, so we'll say we applied her O2. We would watch the pulse ox to make sure that the pulse ox is coming up. Have her take deep breaths in through her nose and out through her mouth. Within about a minute, the pulse ox should rise, and let's say she's at 96% on those 3 liters. If I use 4 liters or more on a nasal cannula, I would want to apply humidification. If for some reason they're on 2 or 3 liters and they want humidification, maybe to help prevent dryness, help prevent them from getting a bloody nose, we can always do that. It's not an issue, but 4 liters or more, we have to do humidification. Okay, so I'm actually going to remove this now that I demonstrated that. We'll say that she's okay for now. We're going to ask you some silly questions, Mary Jean, and I'm looking for her orientation status and her level of consciousness. I see that she is awake and alert for her level of consciousness. She told me her name and her date of birth. I'm going to ask her where she's at. She tells me she's at the hospital, and I'm going to ask who the president is. She tells me it's Donald Trump. So she's alert and oriented times 3 to person, place, and time. She's awake and alert for her level of consciousness. Next thing I'm going to look at is facial symmetry, and I don't see any facial drooping with her. So we have a symmetrical face. Next thing we're looking at is pupils. So we would turn the lights out completely, and we're gonna let her know it's gonna be a bright light in your eye, but we wanna look for the pupils to constrict at the same time. And we call perla is the pupils are equal, round, reactive to light. And then accommodation is look at the tip of my pen and follow it in. So her eyes will cross for convergence. And that's your accommodation. So she is pupils equal, round, reactive to light, and accommodation. Usually pupils are about 3 to 4 millimeters on average, okay? Usually go from 2 to 9. 2 millimeters is completely constricted. 8 or 9 is very dilated. The next thing we will do is check her shoulder strength. So we'll have her shrug her shoulders, and then I'm gonna check the resistance with her head. So I'm gonna put my hand over here and have her turn her head toward the left against resistance. The same thing on the right side. Go ahead and turn your head. She's got good strength in the shoulders, and she's got good strength against resistance with her head turning side to side. Next, I'm gonna have her smile. I'm gonna have her frown. I'm gonna have her stick her tongue out. I'm gonna look for, again, for any kind of facial drooping. If they've had a stroke or there's certain neurological disorders, they may have some facial drooping, or maybe the tongue falls to one side when they go to stick their tongue out. And then we would have her move her arms. So we could say, can you move your arms? And then also, can you move your legs? We'll say she has 5 out of 5 strength, which is full strength with her arms and her legs. I am going to keep her uncovered just for the rest of the assessment so you can see what I'm doing. As I go through, I'm going to look at her skin as I'm going through the whole process. I am going to start up here at the head, and we would want to notice dandruff, maybe lice, bed bugs, alopecia, any kind of pattern baldness issues. Her hair is perfectly fine. I don't see any balding or any issues there. We want to look behind the ears, especially if they have a nasal cannula or tighter fitting glasses. They can get pressure ulcers behind the ears. We want to look, if they have the nasal cannula, at the septum, the nose, make sure that's not getting irritated. And then if they have a mask on, looking at the nose, the cheeks, and under the chin, where that mask sits, because they can get pressure sores there as well. So we've assessed that part of her skin. We're always looking for temperature, assessing for moisture, and then edema could be anywhere in the body. So we're assessing that as we go down too. I'm going to move to the neck and throat. So I'm going to look in her mouth and look at the oral mucosa. It should be pink and moist, and we don't want to see any signs of thrush, which would be a coated tongue. It's a fungal rash infection that goes on. We can notice what's going on with the teeth. We would want to know whether or not she has dentures and be able to look at the gums to see what's going on underneath of that. The trachea, her trachea is midline. We don't want to see any deviations. That means that there's a problem. And then we have our carotids. We do those one at a time for the carotid pulses. We are going to palpate in the lower third, one at a time. We'll say that we got a +2 over there and a +2 over here. And the next thing we're going to do is listen for bruit, and we do that with the bell. And that's listening. Bruits make like a whoosh, whoosh, whoosh sound. So we listen one at a time. If we hear bruit, that means there's some kind of blockage going on. We do not want to hear bruit. And then the last thing we look at with the neck is for jugular vein distension. So we can have her turn her head toward the left. I have the bed at a 30-degree angle, and I'll use my little light. And I'm looking for bulging of that jugular vein. So we don't want to see jugular vein distension. You may see that with some of the heart failure patients where they have too much fluid building up and that vein gets really, really puffy. Most of the time you can tell that jugular vein distension is present just by looking at it, even without a flashlight. All right, the next thing we're going to do is look at the chest. So I'm just gonna bear this down. Again, we would be maintaining as much privacy as possible for our patient. We're going to identify that up here we have the base of the heart. We're going to hear S2 the loudest. Down here we are going to hear S1, and this is the apex of the heart. We also find our apical pulse, which is at the mitral valve, is the midclavicular line in the 5th intercostal space. So kind of nipple line area. And that's where we're going to find our apical pulse. We would listen there for 60 seconds to get an accurate heart rate count, especially if we're giving any kind of cardiac medications. We're going to listen to the different valves. So there's 4 different valves. We're going to listen with the diaphragm first. We're going to go to the 2nd intercostal space on the right sternal border is your aortic. The 2nd intercostal space on the left sternal border is your pulmonic. If we go down to the 4th or 5th intercostal on the left sternal border is your tricuspid. Your midclavicular line, 5th intercostal, that's your mitral, which is also the apical pulse. Again, we would listen for 60 seconds. And then we're going to go back with the bell backwards, listening for any murmurs or abnormal sounds. So you have the mitral. We'll say in 60 seconds, we would want to say whether or not they're bradycardic, which is a heart rate less than 60, tachycardic, a heart rate over 100, irregular pattern, just at irregular intervals. Maybe they have atrial fibrillation, and then also maybe you hear a murmur. So we go mitral, tricuspid, pulmonic, aortic. Okay. Then we're going to do the lungs. So the apices start up here by the clavicles. The bases are down here at the bottom. We do our chest expansion. We're looking for symmetrical rise and fall of the chest with each respiration. We have 5 pairs on the front of the chest, 9 pairs on the back. If you want to listen to both sides, that's fine. Personally, when I roll them over to look at their skin on the back, that's when I listen on the back. We would want to identify whether we hear normal, which is clear lung sounds, diminished, crackles, rhonchi, or wheezing. So we're going to listen to the 5 pairs. We're going to start up at the top. 1, 1, 2, 2, 3, 3, 4, 4, and 5 is out, kind of more lateral. And I would identify if I have any side abnormal. So we'll say that she has diminished bases going on in the anterior, and that's why we put the oxygen on her earlier. We didn't see anything abnormal with the skin. She just has a central line over here. Note that some patients might have a pacemaker or a port placed, so we would want to take a look-see there. Next thing I'm going to look at is her abdomen, and I see that she has a dressing on, so I would want to carefully look under that dressing to see what's going on. And I can do my measurements now, or if you want to do them at the end of the assessment for us, that's fine too. Since I'm here, I will just go ahead and do that, and then I would apply a new dressing in real life. I'm not going to palpate the abdomen or anything because I don't want to stimulate false peristalsis, but I do see that this is a midline abdominal wound. I'm going to measure 12 to 6 o'clock is always going to be your length, and you find the longest length, which is 13 centimeters. 9 to 3 is always your width. Again, the widest part, we're at 2.5 centimeters. And then I am going to get the depth. Okay. And I see that my depth is 2¼ centimeters. We always measure in centimeters. So I see that the inside of the wound bed, is a nice beefy red granulated tissue. That means that it's healing, and that's what we want. And then around the wound, the peri-wound area, there's a little bit of what we call erythema. So it's got just slightly more, slightly darker than pink, but not like an angry red. So we can say slightly reddened and a little bit of swelling, and we would call that erythema. So we've got that. I'm going to say that I did the dressing change on there. I'm going to auscultate before I palpate with the diaphragm. I'm going to start in the right lower quadrant, which is where the ascending colon starts. So going to the right upper quadrant. Then that starts our transverse colon, which is across to our left lower or our left upper quadrant. Then we're going to the descending colon down to the left lower quadrant. We will listen for approximately 1 minute in each. We would want to identify whether we have hypoactive, so think somebody maybe has constipation issues, so the bowel sounds are on the slower side. Normoactive is your average every day. Hyperactive, think diarrhea. The bowels are really moving along really fast. And then absent, they recommend listening for 5 minutes, and that could be significant for some kind of bowel obstruction going on. And then we would palpate, so just gently palpate, ask about if they have any pain while you're palpating, looking for masses, distension. We notice that the contour of the abdomen is pretty flat. So he's or she's pretty okay in that regard. So that is the abdomen. We will finally go into our pulses, and then we will flip on our side to get the back lung sounds and to assess all of the bony prominences in the back. Okay, so we are going to start with our brachials, which are right in here. We check them at the same time. We want to make sure that they're equal bilaterally. So we can say +2 equal bilaterally for the brachials. The radials are here, right at the wrist on the thumb side. Those are +2 equal bilaterally. And I don't notice any skin breakdown on the elbows. I'm going to check my capillary refill is less than 3 seconds. And I'm looking at the profile of the nail. Profile sign, 160 degrees is normal, 180 is significant for clubbing. Then I am going to have her do hand grasps. So go ahead and squeeze my fingers. She has good hand grasps. And then I'm going to have her pull me toward her. And I'm going to have her push me away. So we're going to say she has full strength. Could be 5 out of 5 for her strength with her push pulls and her hand grasps. So we've done those pulses. We're going to go down to the femorals. And if we hadn't looked already, when we looked with our abdomen, if there's skin folds hanging down, we would want to look underneath for any kind of fungal rashes. This is a good time we can look in the groin area for any kind of rashes that are going on, and also just seeing if the genitalia is within normal limits. So I don't see any rashes going on with her. We did our femorals, which is inside. Again, continued with looking at the skin, which looks okay so far. Popliteals are behind the knees. They're really deep. So usually you have to use 2 hands to get deep in there. But 2, that's +2 bilaterally for the popliteals. Posterior tibialis is going to be behind the ankle bone, the malleolus, on the inside. So that's our posterior tibialis. We'll say that as +2 as well. And then the dorsalis pedis is between the great toe and the second toe. And we're going to follow those. And that is our dorsalis pedis. We will say that that is +2 as well. We looked for any kind of edema. We can use our thumb to check for any kind of edema. And I see nothing going on with edema there. We can check our cap refill on our toes as well. Those are less than 3. As people age, they tend to get thicker toenails. So sometimes you might need to apply a little bit of pressure near the nail, but not on the nail, because you're not going to get much to be able to see through the nail, but we want to see less than 3 seconds. We call that blanching. It turns white and then it turns back to pink or whatever the color is for the patient. Then we're going to have her do plantar flexion. So I'm going to say, go ahead and press on my hands like you're stepping on a gas pedal. That's plantar flexion. And dorsiflexion is pulling her toes back. So I'll say, go ahead and pull your toes back toward your nose. And she is doing the dorsiflexion right there. Then we will have you either select or tell you a different range of motion. So maybe flexion, extension, circumduction with the arm, abduction, adduction, pronation, supination. You'll show us an additional type of range of motion. All right, and then the last thing is I need to look at the back side and to get the posterior lungs. Okay, so I'm going to take a look over the skin first, and then we'll do those 9 pairs of lung sounds. Like I said earlier, the back of the head, the occiput bone is back here. We would look at the scapula. Any of the spinous processes, if they're really emaciated, those could also cause skin issues. The sacrum, the coccyx is the tailbone. The ischiums are the sit bones. You could get them on the trochanters on the hips. Of course, the back of the heels, those don't have very much fat, so those tend to break down really easily. So anywhere where they're laying, or it could be maybe they have a Foley catheter and the tube is laying tightly against the skin, that could also cause pressure issues. So we would want to keep an eye out for that as well. You could do chest expansion on the back. And then you have your 9 pairs. Again, remember these start up by the clavicles. And it's very incremental because it's 9 pairs and it's not much real estate here. But my scapulas are here and my spine's right here. So we won't really get much if we listen over the bone. So 1, 1, 2, 2, 3, 3, 4, 4, 5, 5, 6, 6, 7, 7. 8 is out to the side and kind of up. And then 9 is slightly in and down, and 9. Okay. All right, I believe that we have hit everything on there. Then I would go and document my findings for my patient in the chart. We have you write a narrative note about what your findings are with everything: lung sounds, heart sounds, abdominal sounds, how many liters of O2 they have applied, what the pulses are like, so maybe they're +2 all the way through, and then you would turn that into us. The narrative note isn't worth points or anything. It's just to see your process of documenting. All right, good luck.